Alright, recording has started. Present program is that one.
That's the last one.
Yeah.
That's gonna be
So this is Brain Week. So anyone other than Adam can probably answer this, but what is your brain for? Keeping you alive in what way? So let's go from the top. What do you need in order to be alive and therefore the resus? What's your resus order of operations? Airway. What does your brain have to do with airway? That's the second one. Back to you're not supposed to be answering this for lack of this. What is the airway? Yes. You cannot contemplate the thing that you cannot contemplate, i.e. brains. So what is airway about in terms of resus, and what is airway about in terms of not dying? Opening your airways when? When do you not want to open your airways? Swallowing. And what do we call that? Airway protection. Not opening or closing or collapsing or any of those other things that people think about. It's very hard to crack a person's hyoid bone. Yeah, that would close their airway. If you can crack a walnut with one hand, you can do that. I need two hands to crack a walnut. That's all. So airway protection. And if you have a failure of airway protection, what problem do you have and how do you die? Choking and aspirating. And if your lungs fill with stuff, then does that get in the way of breathing? And if your lungs fill with stuff, does that cause infections? Yeah, so airway protection, that's what it's like. Again, back to my usual reference point, which is heroin. What does heroin do to your airway protection? Decreases. And what does heroin do to your stomach? Nausea and vomiting. Yeah, we've seen plenty of that. Yeah, so if you are nauseous and vomiting, but your GCS is low, do you have airway protection? And that's back to airway. What is airway? GCS. If you are fully conscious, you're more likely to protect your airway. If you are less conscious, you are less likely to protect your airway. Does that sound like brain? And that's it. GCS less than 8, intubate. And what is the tube then going to do? Protect your airway. Yeah? Simple med student kind of way of thinking about it. But the reason for that is if your GCS is low, your airway protection is low. And remember, airway protection is reflexes. What are the nerves involved in these kind of regions? Cranial nerves. So if any of those sound like they have the word tongue or below the tongue in them, they are to do with swallowing and therefore not dying, in the sense that if you can't swallow effectively, then you will get stuff going in your airway. Does that make sense? So airway protection and GCS are correlated, and that's why people get intubated. So what's the B? Breathing. And what does your brain have to do with breathing? In what way? That's not your brain. That is your... What tells your diaphragm to move? What part of your spinal cord? Yeah, from where? C3, 4, 5 keeps you alive. Yeah, that is the phrenic nerve. What tells that to action? Somewhere higher up in your midbrain, pons, that kind of area. Yeah, so that's the centers. What are they responding to tell you to breathe? Chemoreceptors such as what chemicals? CO2 or O2 or back to what is the actual reason you die? It's pH, ceviche. Yeah. So what affects your pH? Straight hydrogen ions. What else affects your pH? Sodium and potassium and chloride and all the other things that dissolve in water. Yeah. That's it. If it didn't dissolve in water, it's not necessarily an obvious problem. That is to say, it's just a rock floating around, which would also be bad for you. So airway is about cranial nerves and reflexes. Breathing is about chemoreceptors for pH, oxygen, CO2. Like if you have a CO2 problem, what happens to your pH? Does it stay the same or change? Changes. Now, a low CO2 is just panic. Your pH would go up. But a high CO2 will do what to your pH? Drop it. Does that sound like death? Yeah, 6.7. pH of 6.7. That brings you around to circulation. Yeah, at a pH of 6.7, what happens to your heart? What's going on? Fibrillation. What kind of fibrillation? Ventricular fibrillation. You've put everybody into atrial fibrillation this week. They didn't die. They don't care about atrial fibrillation. Not a problem. Ventricular is death. Yeah, you've all walked somebody in rapid AFib, or they've gone into rapid AFib while you were walking them every single week in cardiothoracics. It's just day 3. It's just a day 3 syndrome. Not the problem. Now, ventricular fibrillation will do what to your cardiac output? Turn it to 0. And then if your cardiac output is 0, are you sending oxygen to your brain?
No.
No, that's the problem. Ceviche. Yeah. What else? How else does your brain control your circulation? Yeah, so autonomic nervous system stuff. And what else? What is the direct connection between your brain and your heart? Which nerve? Vagus nerve, which is cranial nerve number 10. The first three all start with what letter? That'll be another talk. I'm not going to PowerPoint on that. We'll just talk about them. Armando. I'll send you Armando's thing. I'll attach Armando's. Actually, I'll put in the description for all of these talks just an actual link from Armando doing this properly. So airway, breathing, and circulation have something to do with your brain. Yeah. So if I cut your head clean off, there's a problem. Yeah. Conversely, if you stop getting oxygen to your brain, do you lose some of those reflexes? Yeah, and then it's a downward spiral. Like if you don't clear CO2 out of your body, what happens to your pH? Decreases. Now, if you don't clear CO2 out of your body, what happens to your GCS? Decreases. You're more asleep with more CO2 in your blood. And if you're more asleep, do you breathe more or breathe less? You breathe less, so your minute ventilation gets lower. And if your minute ventilation gets lower, what happens to your clearance of CO2? So what happens to the CO2 in your blood? So what happens to your GCS? So you're more asleep. And if you're more asleep, do you breathe more or breathe less? Less. That is literally going quietly in your sleep. That is the best way to die. Too much CO2 causing too much CO2, causing you to just not know it and go out quietly. Yeah? It should. And if it isn't, then it isn't. When you are dying. Remember the difference between trying to not die? If you are trying to not die, are you breathing more or breathing less? That's it. So, dying. This is how we know somebody's trying to not die versus not trying to not die. What are the numbers? I don't care what the difference is. What are the numbers? Yeah. If somebody's CO2 is high, are they trying to not die? Yeah. If somebody's CO2 is low, they're trying to not die. If somebody's CO2 is going up, are they trying to not die? No. Yeah. So that is a ventilation problem. Yeah. Not a respiratory acidosis, a ventilation sad face. And the solution to ventilation is a machine that is a ventilator. And how do you attach a ventilator to a human being? With a tube or a mask. Yeah. That's it. Ventilation acidosis is going to cause more ventilation acidosis. Yeah. Because if it didn't, it wouldn't. But it is, so it is. Does that make sense? You don't have to worry about the whys. There's 700 whys. Look at the person, yeah? If somebody has a C2 spinal cord injury, yeah? Is their brain able to tell their phrenic nerve to pull? Is that the problem? And it's called a hangman's fracture for a reason. Yeah? Because how do you die when you get hung? Snap your C2. Can your brain talk to your spinal cord? No. Can your brain tell your diaphragm to move? No. So do you breathe? No. Your airway's fine. You've got airway protection, but you have no breathing. Does your heart keep beating? Yeah, because your heart will work independently. But if you're not breathing, are you getting CO2 out? Are you getting oxygen in? So what gets you first, the CO2 problem or the lactic problem? Lactic. Because if you don't breathe, you don't get oxygen in. So if you don't get oxygen in, do you have glucose proceed to the Krebs cycle and produce CO2? No. Same problem. Metabolic or respiratory, if you just think about zero breathing, they are the same problem. That make sense? Either way, it's a gas movement issue. Can I just stick a tube in you and then move gas? Yeah. So if you haven't completely destroyed your spinal cord, there is some possibility of recovery. Make sense? But if you have, well, are you going to be permanently ventilated? We have patients that are permanently ventilated quadriplegics. What do they have? A machine that goes ping attached to their wheelchair, and they drive their wheelchair around. I ran into one of them at a laneway festival. Knew him from here. He was at a music festival. He's at the back of the mosh pit, and we jammed. Ventilator dependent quad. That's all. Yeah, exactly. Yeah. Does that make sense? So why is it? Because it is. Don't ever worry about the why. The why is why they're in hospital. You don't have to work that out. Yeah? Somebody has gone through all of those things to go, well, it's probably this. Like if you just have really epic Guillain-Barré, yeah, do all your nerves stop working? That's it. So does your diaphragm work? Is your brain able to tell it to work? No. Yeah. So that is a neuromuscular weakness. If you have too much heroin, does your brain receptors for CO2 work better or worse? Worse. So then you don't have the CO2 drive to breathe. And they're the people that do have the O2 drive to breathe. Yeah. And they'll do this thing called Cheyne-Stokes breathing. Yeah. Problem A, but you're still breathing some, but not enough. Yeah. And then problem B is you're not protecting your airway. Yeah. So if you get not enough gas movement, your pH goes south. And then if your pH goes south enough to less than 6.7, you go into VFib. And that's your respiratory arrest precipitating cardiac arrest. Yeah. But it can go the other way. Your heart stops beating. Are you moving blood back to your lungs to gas exchange? No. Same idea. Yeah. So, brains. Good for airway, breathing, and circulation. And the point of airway, breathing, and circulation is to get at least 20% of your cardiac output to your brain and have it oxygenated enough that your brain can keep ticking over. If your brain stops ticking over, can you do anything? No. Can we make you breathe with a machine? Yeah. Can we feed you with a machine? Can we artificially just be your heart with a machine? Yeah. And you can do all of those things to bridge somebody to whatever they need. Yeah. So if your heart has completely failed, can you just get another heart? Not easy, but it's possible, and so on. Does that make sense? So, don't worry about these specific words. The idea is that these things have names, and for the most part, you just need to know where the front and the back and the left and the right are. So when looking at any CT scan, this person is lying on their back, so their nose is at the top. Yeah? And the person is lying on their back, so their occiput, the back of their head, is that side. Now, it's like an X-ray. Yeah, when you're looking at an X-ray, your right hand and the right-hand side of the screen is pointing at the person's left side of their chest. Yeah, so it's the same in this. That this is the left side of the person's brain on that side of the screen, where where my right hand would point. Now, how do we get to that? Well, if you're lying on this table in front of me, and your feet are at my end, yeah, then that is your left side. Yeah, like if you were standing up, that is your left side. Does that make sense? So that's one of the difficult bits. Now, all these things have names. The most important thing I want you to understand is, as long as you can find vaguely where the problem is, then you can read the the X-ray report, but after the fact, and then learn the names that way. Yeah. You think I know what caudate and dentate and all those kind of things are? No. Something about basal ganglia, something. Yeah? And the basal ganglia region is this bit in the middle, which is the midbrain. Yeah? This is your midbrainy section. Make sense? Oh, there, wherever that mouse is going now. Yeah? Why? Because it's in the middle of the brain. Yeah? And then the frontal is at the front, and then the occipital is at the back, and then your temporal and parietal are around the sides there. Yeah? So, things that are strange and we've pointed out before, and there's a reason why we point them out. Oh, I lost my mouse. There it is. You see this thing right in the middle that's bright white? Yeah? See that bit? Oh, and the mouse disappeared. But the bright white thing right there is the same density as bone. So it is calcified. Does that make sense? So the more dense, like in X-rays, yeah? You guys were learning about X-rays and fractures. The more dense something is, the whiter it is. The less dense it is, the less white it is. Yeah, and it's how many X-rays are blocked or absorbed versus how many hit the plate. So if you're outside somebody's head, there's nothing but air, plenty of X-rays hit the plate, nice and black. In the middle of your brain is the ventricles, and the ventricles are full of CSF, so that CSF is water. So again, what color is water on an X-ray? Fairly black, but not as black as air, yeah? And then everything else is, well, fat and protein, really. So think about the rest of your brain as fat and protein, different density to water. More dense in the sense that there's more of it there, yeah? Other than that, your brain is separated into obviously lobes and sections and whatever else, but just think about the cortex, yeah, as the bit where all the actual nerve cell bodies are, yeah? You know, you'd refer to that as your gray matter versus your white matter. Now, what is the difference between the gray matter and the white matter physically? Like what? Axons and the body is the body, and the axon is the connecting fiber. What is wrapped around the axons? Myelin. What is myelin? Non-conductive. It is insulating. Yeah, because you want to protect, like a wire, you want to protect the inside of the wire from the outside. So it's made of fat, which is less dense than the protein of the cell bodies. Does that make sense? So when you're thinking gray matter versus white matter, we mean cortex versus axons. And the cortex will be more dense, and the axons will be less dense. Yeah, but they're still more dense because they're more tightly packed together. They're more dense than the water density in the ventricles. Yeah, that's a very important distinction. And they'll talk about that as gray-white differentiation. But because it's the reverse of that, it gets confusing. But just remember, the cortex is the outside bit, yeah? And then everything else is the connecting fibers. So, choroid plexus. What does the choroid plexus do? Create CSF, and it lives inside the ventricles. And see how that is kind of bright white there? Yeah? And it's bright white because it is calcified. It is not blood, yeah? We'll get to later what blood looks like, but it's calcified, and that's the importance of knowing that, in that is just a normal thing that is white and looks a bit weird. All right. Blood is thicker than water. That's the most important way to remember a lot of this stuff, yeah? This guy in the first one is relatively normal. So in the middle you have your ventricles, and that space is full of CSF, and around your brain you have CSF, and then you've got gray-white differentiation. What's going on in this second one? There is white stuff that shouldn't be there, yeah? Let's not assign anything specific yet, but there is stuff that's more dense in the brain, yeah? Should there be stuff there? No, because the blood should be inside the blood vessels. But as you can see, that blood is traveling along the pathway outside the blood vessels. Where'd my mouse go? Yeah, so this is literally the pathway for the mid-cerebral arteries going left and right, the anterior cerebral artery going up the middle, and then the posterior cerebral arteries wrapping around the pons. Yeah. See, there's the pons. Yeah, and see, it's kind of like got a weird wig on that's white. Yeah, that's the posterior cerebral artery pathway, which should just not actually look like that, because you don't see blood, because blood when it's coagulated looks like that. Yeah, whereas blood that's moving does not appear like that. If that makes sense. Because it's not as dense. Yeah, a blood clot is more dense than water, let's say. So this is a bit of a classic subarachnoid hemorrhage. Yeah, how you determine each of these is not really important. I just want you to understand that white stuff that shouldn't be there is hemorrhagic. Yeah. Now, where's my mouse gone again? That is your classic following the pathway subarachnoid hemorrhage. This is white stuff within the brain. So it's an intraparenchymal hemorrhage, intracerebral hemorrhage, yeah? But you can see it's white stuff that shouldn't be there. Either way, is that going to be space occupying? Yeah, and they are arterial bleeds, so they're high pressure. So what's that going to do to your intracranial pressure? Increase it very quickly. Is that going to make you feel very headachy? Yeah. So in terms of acute stroke, yeah, one of these two, sorry, numbers 2 and 3 in this, will be a very acute hemorrhagic kind of stroke. Yeah. So what is the other kind of stroke that's not hemorrhagic? Ischemic. Now, what is the likelihood, that is to say, of 100 strokes, how many would be hemorrhagic and how many would be ischemic? Which one? Which one's more common? Ischemic is more common. 80%, 80 of them would be ischemic, 20 of them would be hemorrhagic. What are your signs of stroke? Face what? Yeah, fast. Fast. F-A-S-T. So F is for face. What's going to happen with your face? Drooping. Asymmetry. What nerves tell that what to do? Cranial nerves. Yeah. A is for arm. And what about the arm? Weakness or coordination. Yeah. You got strength, but you can't find your mouth with your chopsticks. Yeah. Or you can't use your chopsticks. Coordination, but you got strength. Yeah. Where would that stroke be if you had a coordination problem? Cerebellar, posterior circulation. Yeah. Way more likely to kill you, which we'll get to when we're looking at scans. But always remember that. Much less actual physical dysfunction, but much more likely to die. What do we get to? S for speech. What about it? Slurring. Yeah, so slurring is dysarthria. Then you have dysphasia, where you've lost the words. Yeah, or dyspraxia, where the words are all jumbled up. And then the actual problem that'll kill you is dysphagia. Yeah, swallowing. And again, back to what is that? Cranial nerves, airway. Yeah, airway, facial, airway, dysphasia, phagia, and all those kind of things. That's how we die. So I bring it up very early in the piece. So this next one, this picture number 4 here, see the blood is around the outside, yeah? But the brain itself has just been pushed across. So this thing that's more like a C shape is going to be a subdural hemorrhage, yeah? So you can actually see, if you look very closely at this brain, that the blood does not go into the folds. It doesn't go into the CSF spaces. So see right there, there's kind of CSF going down into the folds, but not blood. So that is blood in the subdural space, not in the subarachnoid space. What is the difference? Well, blood that's in the subarachnoid space, like this one, yeah, has crossed your blood-brain barrier. Yeah. So subarachnoids are arterial bleeds. Subdurals are venous bleeds. So is a venous bleed going to be high pressure or low pressure? Low pressure. So will that be the acute stroke signs? No. It will be stroke signs somewhere down the track when there's enough pressure to squash one side of your head. Yeah? Does that make sense? Now, which one is more likely to kill you? An arterial bleed. Yeah? Which one is much harder to fix? A venous bleed. Because it's a mesh and it's very hard to find the bleeder. So what do? You drain the blood out. And sometimes the bleeding stops and sometimes the bleeding comes back. Make sense? So that's your chronic subdurals or your acute non-chronic subdurals. How do you drain anything out? Make a hole. Filling up with water. Yeah, that's it. Can you drain blood in the folds if it's a subarachnoid bleed? No. Can you drain this blood that's in the middle of this guy's brain? No. So if you have an arterial bleed and a high pressure problem, we can't drain the blood out, but what can we do to reduce the pressure in their head? Drill a hole and put what in? An EVD. Yes, so what are we draining out from the V? You can't drain the blood out. You are accidentally getting blood, but you're not draining the blood. What's in the ventricles normally? CSF. That's it. If you drain CSF, what happens to the volume of stuff inside your head? Yeah. And what makes CSF? Choroid plexus. And how much CSF do you make a day or an hour? Any thoughts? How much do you make a day or how much do you make an hour? What do you think? CSF. A cup would be 250 mils? Per hour or per day? Per hour? So more like 300 and something a day? Yeah. What do you think? 800 mils a day?
301.
301? And? Pick a number.
12 mils an hour.
12 mils an hour. So that would be about half of the actual thing. So 12 mils an hour is going to give you the same answer as ARM. The answer is 500 mils. 2 metric cups, 1 pint a day. So about 20 mils an hour. Yeah. 20 times 24 gives you close to 500. No. Where does CSF normally go? South. Yeah. And how does it get south? Through the cerebral aqueducts, which is your fourth ventricle and all that kind of stuff. So back to a posterior problem, cerebellum problem. A cerebellum problem will squash your fourth ventricle. If I squash your fourth ventricle, what happens to CSF? Stops moving. So what happens to the pressure inside your head? Increases. And is that going to squash your brain? Is that going to squash your pons? Yeah. Brain gets squashed, man. Think about all the problems we've always talked about, ceviche. The answer is always ceviche. What's the problem? Ceviche. Why? Flow. Yeah, increased intracranial pressure reduces perfusion pressure. Yeah, so all these things will increase your intracranial pressure to some degree, some faster than others, and some more chronic than others. And this is just what probably is traumatic, this last one, because there's stuff inside, outside, and everywhere. I cannot see any obvious egg on the person's head. But the point is, if you see bright white stuff, that's blood. If you don't see bright white stuff, it's probably not blood, and therefore, what kind of stroke? Yeah. So this is where knowing your circle of Willis vaguely helps, yeah? Now, first and foremost, blood has to come from your heart. So what are the arteries that come from the heart to your circle of Willis? That is to say, the ones coming up. What's the two at the front called? Carotids, and particularly they split into internal carotids, yeah? So the internal carotid will be, where's my mouse gone? Kind of just this guy here and opposite him, yeah? And then what are the two at the back called? No, coming from down here. Yes, I squeezed your neck really hard to demonstrate where that hurt. And what hurt? The vertebra. So what are those arteries called? Vertebral arteries. Yeah, and the two vertebral arteries come together to form the basilar. So if you see two arteries coming together to form one thing, that is vertebrobasilar. Yeah, and this is how you interpret these things. That's the blood flow, vertebrobasilar. In the circle of Willis, it's a circle and blood can flow in all directions to make up for narrowing or something. So if you're looking at a scan and you see two arteries very close together, that is the anterior cerebral arteries, yeah? And therefore, if you look left or right from there, those are going to be the mid-cerebral arteries, yeah? And then the other ones are the posterior cerebral. So if you're looking at the territory supplied, I'd basically just draw vague triangles through, vague lines through the ventricles. Yeah, and then you've got anterior cerebral artery territory, posterior cerebral artery territory, and mid-cerebral artery territory. So if we're going to look at this guy on the right-hand side of our screen, yeah, which side of the person's head is the problem? Their right side, yeah? Our left hand, but their right side. So what territory is the problem? Mid, because it shapes in that shape. Now, looking at that problem, is the brain itself whiter than it should be or blacker than it should be? More like blood or more like bone or more like water? Water. So how do you get water somewhere that shouldn't be there? Think of the normal, regular thing like you rolled your ankle. Inflammation. So we're not seeing any of those words you were using. We're seeing water that shouldn't be there. How do I know? Because it is less dense than brain. The CSF space is water, which is less dense than brain. So what is here? Water. What am I seeing? Inflammation. How do you get inflammation somewhere? Sad face. All pathologies look inflammatory. Does that make sense? So what are you seeing? Inflammation. None of this core penumbra or the other bullshit people use. You're seeing the inflammatory process. Now, if you had a stroke and I got you in a CT scanner within 5 minutes, have you actually killed any brain cells yet? No. So would I see any inflammation very early in the piece? Not until you've started to cause some damage. Does that make sense? So when you see the inflammation, that is the response to the damage. It is not the damage, it is the area that the damage occurred. Does that make sense? That's very important, yeah? None of this core, penumbra, whatever else. I've looked at a whole bunch of scans and none of those things mean anything. Yeah, we can go through perfusion and whatever else. Just think about this as where is the problem on the patient's left side, on the patient's right side of their head, yeah? In terms of the scan. Now, where would we see that problem in terms of assessing the person? Right side of the body, yeah? So other than me looking at this and looking at the patient to go, well, I reckon there's going to be a problem on their right side, does anything else matter? No. And back to what are we going to assess? Function, yeah? Not manual muscle testing, function. Best way to assess function is high five me. Other hand. Does he have any asymmetry? No. And most importantly, you reckon if I asked him, could he hold his arm at 90 degrees for 3, 5, or 10 seconds, depending on where you went to school? No, like you literally, if you're at one hospital, they'll say 3 seconds. You're at another hospital, they'll say 10. Everyone's wrong. Why? Because you need a sling or don't need a sling based on whether you sublux or not. Yeah. If you can hold it at 3 seconds, it doesn't say you won't sublux, but it's less likely. Yeah. Why? Because if your brain isn't controlling that shoulder, what's your risk of subluxation? High. So if you have 0, then it's pretty highly likely to sublux. So that's my test. Do I need to do anything other than high-five me and then touch your nose? That is that test. Is that your cerebellum? Yeah. Is it also, do you have an anti-gravity with your arm? Probably. If you can high-five me good, you've got anti-gravity good. If you can hit my hand and hit your nose, is your cerebellum okay? Yeah. Do I care beyond that in ICU? Shit, no. You just don't need a sling. Yeah. Now, what's the other thing I want to assess? Get to that. Keep that separate. We're staying with function. All those things come into it, but they're not necessarily our, like, not dying is part of it. Assume you're breathing and you're not dying. How do we get to checking balance? Remember, back to how do I assess somebody's chest? Do I pull out a stethoscope or do we just check their straight leg raise and get them out of bed? Yeah, check their straight leg raise and get them out of bed. Can I just ask this person to do that? Yeah. And if you can straight leg raise, what's the likelihood you can probably stand up? Yeah. Now, what is the likelihood you'll be okay in a chair? Well, that's how we check your balance. So how do we check your balance? Sit on the edge of the bed. See what happens. That make sense? Now, if you want to do sitting balance and they don't have shoulder protection, what's the risk? Yeah. So what do we need? A sling. Yeah. Now, do I need to go through whether you're grade 5 or 4 in your frickin' intrinsics to do that? No. Don't care in the ICU. Later problem. Yeah. How do I know that's a later problem? Well, think about edema. Does edema stay the same as it is from the first moment you have it, or does it get worse, or does it get better across time? Gets worse across the first? 48 to 72 hours. Yeah. Think about edema in your ankle when you roll your ankle. Yeah. Now, edema in your ankle goes away pretty quickly because you have lymphatics, so it takes about a week to go away. Yeah. Does your brain have a lymphatic system like your ankle does? No. So how long does it take? More time or less time for that edema to go away? That's it. 6 weeks. If you want a number? About 6 weeks. Yeah. So again, like if you have edema, does that squash nerves? And if you squash nerves like your arm, does your arm work? So if you squash nerves for 6 weeks, will the nerves work very well for 6 weeks? That's it. That's your natural recovery and freaking whatever people talk about. Yeah. But the way I learned this was so terrible. I didn't understand why we were doing anything. Yeah. So I stopped trying to understand why we do anything and just do things. Why? Because somebody told me sitting balance was important for acute stroke patients. Why is sitting balance important for an acute stroke patient? So they can sit in a chair, which is better for their lungs. So if I can treat somebody's lungs by having them in a position that's better for their lungs, does that make my life easier for what you were saying? Yeah. So am I assessing their chest or just treating their chest? Treating it. Yeah. Yeah. So that's the important thing. Now, if you have sitting balance, are you more likely to be able to stand up and do all that other stuff? Yeah. And if you don't have sitting balance, is any of that stuff easy? No. So where do we start? With the thing that makes the rest of them easy. And most importantly, as I got told, sitting balance allows you to get to rehab sooner. And if you get to rehab sooner, are you less of my problem? Yeah. So do I have to do as much stuff with you? No. I'm reducing my own work by doing the thing that gets them out of my hair sooner. Yeah. They're going to get out of ICU soon anyway. They're in there for maybe a day or two. But then they'll go to the neuro ward. But then if they're on the neuro ward and they have sitting balance, they'll go to rehab sooner than somebody that doesn't. That's the important thing. I got told that 20 years ago, and I just repeat that. And I don't have to understand why. Does it change what I do, whether I understand it or not? No. I can give you some vague answer, but everyone's answer is vague, and we're all wrong. Yeah? I guarantee you neurology changes every 5 years in drastic ways. Yeah? For a decade, I would say there is no lymphatics in your brain. And suddenly they find a vague mesh network that's a lymphatic system in your brain. Students sat here and said, well, I've got a paper, and I've read the paper and went, yep, I will quote her. Still friends, still argue about stuff. It's a very vague mesh network that, it's like they found a weird, they called it another organ, but it's like your mesentery has, again, this vague mesh network, which you never see if you're dissecting somebody that's dead, because they empty out and they collapse. Yeah. Yeah. Same kind of concept, but in your brain. Yeah. Yes. All of those things. Yeah, you think, oh no, anatomy is the same. Oh no, read a textbook from my day versus a textbook from your day. There will be changes in anatomy. We're all wrong. We just try to be less wrong. That's why I don't want you just trying to use signs and whatever else to say dumb stuff. Just point at where the problem is, think about what that would mean for the patient, and then go and look at the patient functionally. Yeah, in ICU, your edema gets worse and gets better. So you may have to do this test every day. Yeah, because if your edema is worsening and your arm was good on Monday, is it going to still be good on Tuesday? Maybe not. Yeah. Will there be a problem that gets worse? Of course there will. And if you're doing very terrible manual muscle testing, yeah, and reading other people's manual muscle testing, particularly that you didn't do, you're going to think something is better or worse based on the numbers that aren't true versus some test that it's very simple to do and therefore you will do accurately, which is high five me. Yeah. If they can't high five you, that's the problem. If they could high five you yesterday and they can't now, that's the problem. If they couldn't high five you yesterday and they can today, there you go. Has the problem gotten better? Yeah. Because the nerves just go into a bit of shock and then wake up the next day. Yeah, particularly if you have, well, what causes an ischemic stroke? Lack of oxygen. And if you have a lack of oxygen, what is the problem? Ceviche. Lack of blood in and blood out. So what are you not bringing in? Oxygen. And what are you not carrying away? And what else? Where does the carbon dioxide come from? So what else do you have to bring in other than oxygen? Where's the carbon come from in carbon dioxide? Correct. Specifically, glucose. Yeah? Can your brain run on things that aren't glucose? Yeah, ketones. Either way, how do they get to your brain? Like through your skull or from your blood? So if you're not bringing blood in, you're not bringing oxygen in and the things you need to burn. Yeah? And if you burn things, you generate CO2 and the words burn. So what else are you generating? Heat. And accidentally water. Yeah? Because the hydrogen goes back to somewhere. So if you generate heat and you don't have enough water to carry that heat away, think about your car. Well, you too. These guys aren't going to know. What do you need in your car to carry heat away? Coolant. Yeah? Water. Yeah? Yeah? The turbo in your Type R. Yeah? So the heat needs to be carried away. If you don't carry heat away, what happens to the brain? Yeah, and what temperature do you permanently cook? No, you've had a higher temp than that, like this year. 42. 42, you start cooking like an egg. Yeah, does that make sense? So what's happened in this section of brain? All of the above. Yeah, can I tell you what things are completely dead versus what things are partially annoyed versus what things are just being squashed by the annoyance? No. But do I need to? No, because testing you functionally gives me all of the answers without having to worry about that. Yeah, always test the person and test the person regularly. Yeah, and you will see if they have a blockage. So again, this is the CT perfusion scan. If they have a blockage, what this is telling us vaguely is that there is a problem on the my left hand, so the right side of their brain. Yeah, and for simplicity, let's just call red bad. Yeah, so do we have an asymmetry of color in this scan? Yeah, and where's the problem? On the patient's right hand side, my left hand. Yeah, and that is about time to peak, and then over on this next image here is about cerebral blood flow. So in this case, if basically lack of blood flow is this blue color. Yeah, people use the word like core infarct and whatever else. It doesn't mean anything. Like, it's just like literally penumbra. You know what penumbra comes from? Eclipse. So you have umbra, total eclipse, and penumbra, which is the bit around the eclipse. Now think umbra as a Latin word. L-R-A-A, yeah. That's it. That's literally what you're saying. Shadow. Partial shadow. Annoys the hell out of me. Yeah? All I need you to do is look at the person and do something with them. Because if you look at this scan and you think, well, they're cactus, I'm never going to do anything with them, is there any hope that they ever actually get better? Yeah. Now, Does that help you assess somebody? No. You're assessing somebody. Somebody helps you assess somebody. Looking at this and thinking, oh yeah, no, they've got no hope. I'm not going to bother. Is that going to be good for them?
No.
No. Look at this for the vague suggestion of problem or not problem, side or not side, and then go and look at the person. Yeah. Because if you look at this and you see what you think is the problem, and then you go look at them and they have other problems, what's the likelihood they have two problems? Yeah. Does that make sense? There's more problems or weirder problems. Yeah. That's the important thing, particularly for something that's not the obvious left side or right side, because it's not the mid-cerebral artery. It's a frontal or it's a cerebellar or something like that. Yeah. They're the same level and they're measuring different things. So time to peak is peak oxygen kind of uptake and all that kind of stuff. Yeah, blood flow. Sufficient to say if you see an asymmetry in this image right there, see that looks asymmetrical to that side, and similarly that looks asymmetrical to that side. Your asymmetry is the problem, and then you've got to work out which of those asymmetries you reckon is the side of the problem. Does that make sense? Yeah. Now, within this is a CT perfusion scan, so you'll have the CT angio, and you'll see their blood vessels. But yeah, for sufficiently, I just call red's bad generally, because what you can often tell is, like we did, you look in front and behind. Yeah, and that should help. Yeah. Yeah, yeah. So if when in doubt, just assume that you are confused, because you are, and go and look at the person. Because if this scan looks like this and they have no obvious deficits, is that a good thing? Yeah? Because if you have a blocked artery, how do they unblock your cerebral arteries? If that's a carotid or something like that, but the actual blockage, how do they fix the blocked part of it? Not thin the blood, not anticoagulant, because that just stops the clot getting bigger, the thrombus getting bigger. Yeah, you need to break the thrombus down, and that is called thrombolysis. Thrombolysis, TPA, something that breaks the actual thrombus down. Yeah, and then restores blood flow. And the other version of that is the ectomy, but you go in through the like an angiogram for your heart, but you turn this way, and you go and find the blockage, and you slide a stent over the top of it. But the stent isn't one that goes like that, there's one that goes like that. So you have a balloon to slide the stent over, and then when you deflate the balloon, it grabs the thrombus, then you grab the stent and pull the thrombus out. Thrombectomy, endovascular clot retrieval. Endovascular, from the outside to the inside, grab the thing and pull it out. ECR, endovascular clot retrieval. Yeah, physically pulling the plug out. Thrombolysis is chemically dissolving the plug. Yeah, I use the word plug, not clot, because clot, you know. See that? That's blood that's clotted. But am I using the word thrombus and embolus or hemorrhage and hematoma? Hemorrhage and hematoma, blood outside a blood vessel. This will be an occlusion inside a blood vessel. Yeah, the right mid-cerebral artery occlusion. Yeah, so that would be thrombolysis. So back to, if you have two kinds of strokes, one's hemorrhagic and one's ischemic. Yeah, if you can very quickly determine that it is a hemorrhage, do I want to give somebody thrombolysis if they're already bleeding?
No.
So they would keep bleeding more and worse, and they would die. So first establish it's not a bleed, and if it's not a bleed, what's the likelihood that it's ischemic? Very high, because most horses rather than zebras. Yeah, ischemic events are horses, hemorrhagic events are zebras. Not zero possibility, but much less likely. Make sense? So the idea is, if it's not hemorrhagic, and you can give them thrombolysis, TPA, which is within the first, so FAST, the last one in that acronym is time. You want to have the blockage unblocked within 4 hours, 4.5 hours, or thereabouts, with thrombolysis. Yeah, you can unplug somebody much later beyond that, but you're uncertain as to how much recovery they may or may not get. Yeah, so in the modern day, when you unblock people one way or the other, will you kill less brain cells? Yeah, and therefore will you have a much more significant physical recovery? Yeah, that's all. There are risks to doing those things, but the functional restoration is really high, because this outer part of your brain actually has a pretty long tolerance for ischemia. Does that make sense? So you know how you learn you're going to lose brain cells within 3 to 5 minutes? That's not your entire brain. That is like this mid-brainy basal gangliary kind of stuff. Yeah, somewhere deep in there probably has a 3-minute window because it's very, very oxygen intensive. Yeah, and because it's got a circle of blood flow around it, it gets plenty of blood all the time. Now, again, part B of that is, well, if you block one of them, but some of the others are getting blood vaguely in that direction, that might help. Yeah, midbrain is very energy intensive. So the cortex is actually a lot more, we'll say, durable in that sense. Yeah. So if you can restore blood flow within 4 hours, you haven't killed brain cells, you've just annoyed them. And if you have annoyed them, but they're not dead and they haven't exploded, what's the likelihood they'll just come back to being okay? Much higher. Yeah. So you're improving your natural recovery, you're decreasing your long-term disability. Does that make sense? So the ischemic territory is very hard to see very early in the piece, and then it evolves over time with inflammation, just like rolling your ankle evolves over time with inflammation. And the only way to know what the problem is to physically test them and then do stuff. Yeah, that's why early in the piece I never particularly focus on manual muscle testing any more than check the thing that we will treat, which is, do I need a sling on them, and check their legs to just have a basic idea. So if you have good leg strength, we might be able to get away with 1 or 2 people. But if you are a large person and have no leg strength, do I still want to do sitting balance with you? Yeah. But am I going to just do that on my own, or am I going to have more than 1 person? Yeah. Safety. Yeah. Since I always have you guys, we always have 3 people on the job. 1 at the back in the catching position, and then 2 in front. Yeah. And then that way, if all's well, then we can put somebody on knee control. So if somebody is really weak, but you can give them some knee control on their affected side, can you still stand them up with their good leg? Yeah. Does that make them happier? Yeah. Are you doing anything that's actually super therapeutic in terms of goal setting or whatever else? No. But if you put the idea in somebody's head that they're not going to die in hospital and they can stand up and their family can see all that, you get all the psychology and the placebo and everything else kicking in really well. Yeah. If you show them a pathway out of here early in the piece, does that give them a better, I guess, interaction with rehab they're on in? Yeah. And that's what we're doing. Very early in the piece, very early rehab is, whether it works physically or not doesn't matter. It is the sign that there is a pathway to get out of where you currently are, get out of the ICU. Yeah. So in the ischemic ones, they're usually in ICU for a day or 2. And in the hemorrhagic ones, they might be in ICU for weeks. Yeah, with the EVD and all that kind of stuff. But then can you do sitting balance in somebody with an EVD? Not easily. Yeah. But when all that stuff comes out with Michelle, what are we doing with her? Sitting balance. Does she have sitting balance? No. We tried it a few times to see what would happen. Didn't happen. Yeah. Yeah, she had bilateral EVDs for a while. Yeah. You're in a world of hurt when you get 2 EVDs. Does that make sense? So anyway, we'll go through some scans for the next few days. And then